Somatic symptom and related disorders, or some tales of medical mysteries. The learning goals of this lecture are to understand the concept of abnormal illness behaviour, to develop a knowledge of features of somatic symptom and related disorders, including their epidemiology and risk factors, the differentiation between somatic symptom, factitious and malingering disorders, and principles of treatment, and, in particular, what to avoid in treatment. Starting with some key concepts of illness behaviour. Stop and think for a minute. What is normal illness behaviour? Or what do we expect from patients? We expect them to seek help, to be concerned about their illness, to therefore want our advice, and to follow our advice and adhere to treatment. On the contrasting side, what then is abnormal illness behaviour? We don't expect our patients to ignore our advice, not adhere to treatment, and not to be interested in wanting to get better. The definition of abnormal illness behaviour comes from a classic paper by Professor Pulaski in 1977. It is the persistence of a maladaptive mode of experiencing, perceiving, evaluating and responding to one's own health status, despite the fact that a doctor has provided a lucid and accurate appraisal of the situation and management to be followed, if any, with opportunities for discussion, negotiation and clarification based on an adequate assessment of all relevant biological, psychological, social and cultural factors. So how does abnormal illness behaviour come about? Why would people have anything to gain from illness? Primary gain is a conscious or unconscious or partly conscious satisfaction of a need and or avoidance of a conflict in classic analytic terms. For example, a child who is being bullied may avoid going to school by complaining of sickness. Secondary gain is where there's more advantages conferred by being in the sick role than not being in the sick role. For example, an unwell child discovers they get more parental attention. In the majority of psychosomatic illness, we can see these issues around abnormal illness behaviour. The main psychosomatic disorders you need to know about are the somatic and related disorders. These are often associated with depression, anxiety, and personality disorders, and one example is child-onset fluency disorder, otherwise known as stuttering, which is associated with severe social anxiety. And if any of you have seen the movie The King's Speech, this was depicted very well in that movie. Dissociative disorders you will need to read more about. They'll not be covered further in this lecture, but they are important, and they include psychogenic amnesia, fugues and identity disorder. Body dysmorphic disorder you will have another lecture about, and eating disorders I will cover in the next lecture. In the DSM-5, somatic symptom and related disorders include somatic symptom disorder, which may be with persistent pain, previously known as pain disorder, illness anxiety disorder, psychological factors affecting other medical conditions, for example anxiety that exacerbates asthma, conversion disorder, factitious disorder and malingering, and other specified or unspecified somatic symptom disorders, which include pseudocyesis or having a false pregnancy. In the DSM-5, somatic symptom disorder includes a range of previous diagnoses of somatization disorder, undifferentiated somatoform disorder, hypochondriasis, pain disorder, and pain disorder with and without psychological factors. In your textbooks, if they haven't been updated to DSM-5, or reading papers before the DSM-5, you will find these other terms quite commonly. In the DSM-5, there is a de-emphasis on medically unexplained symptoms, as a way of defining or thinking about somatic symptom disorder. I'm not sure I entirely agree with this, but it is a way that we often start to think about, has this person got a somatic symptom disorder? However, we have to realize that merely having medically unexplained symptoms does not mean you have a somatic disorder, noting that medically unexplained symptoms occur 3 times as commonly in patients with general medical illness, including cancer, cardiovascular and respiratory disease, compared to the general population. The criteria for somatic symptom disorder are having one or more somatic symptoms, such as pain, that are distressing or cause significant life disruption. The person will also have excessive thoughts, feelings or behaviours related to the somatic symptoms or health concerns as manifested by either disproportionate and persistent thoughts about the seriousness of your symptoms, and or having persistently high levels of anxiety about health or symptoms, and or having an excessive time and energy devoted to these symptoms or health concerns. And although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent, and typically this is for more than 6 months. And then there are 2 specifiers. One is that pain is predominant, and the disorder is persistent. Illness anxiety disorder is defined as having a preoccupation with having or acquiring a serious illness. In old terms, it was known as hypochondriasis. Somatic symptoms are not present, or if present are only mild in intensity, which distinguishes this from fibromyalgia and irritable bowel syndrome. If another medical condition is present, or there's a high risk for developing a medical condition, the preoccupation is clearly excessive or disproportionate. There is a high level of anxiety about health, and the individual is easily alarmed about their personal health status. There are also excessive health-related behaviours, for example, repeatedly checking your body for signs of illness, or the person exhibits maladaptive avoidance, for example, avoids actively doctor's appointments. The illness preoccupation is present for more than 6 months, but the specific illness that is feared may change over that period of time and is not better explained by another mental health disorder. There are 2 specifiers: people who are care-seeking or people who are care-avoidant, and as I said earlier, about 1/4 would have formerly had a diagnosis of hypochondriasis. I now want to just take you through an example of this disorder. This is from Noel Coward's autobiography, Present Indicative. Noel Coward was an English dramatist and writer in the first part of the 20th century, and he's writing about his experiences in the First World War, which he described as brief and inglorious. He did manage to extract himself from what he described as an unpleasant position in the Labour Corps and was transferred to the Artist Rifles, but couldn't adapt himself to new circumstances. His stage life had ill prepared him for the discipline other than of the theatre, and in the army his individuality did not count. He said he couldn't wipe his mind clean of mother and home because he had been the chief income earner for the family, and his transfer into the army rendered his mother relatively impoverished. He said, "The needs of my king and country seemed unimportant compared to the vital necessity of forging ahead with my own career and getting his mother out of that damn kitchen." So soon unfamiliarity, hard routine, coupled with my inward miseries, began to affect me physically. I developed cracking headaches and was unable to sleep. So after suffering a moderately severe head injury and some weeks of convalescence, his severe headaches began to occur and he was referred on to Colchester Hospital. The diagnosis of a brain tumour was considered and by both himself and his doctors, and he stayed in the ward for 2 months. And then he began to worry about his health and that he might have problems such as he saw of the people around him, such as epilepsy. When I questioned the nurses, I wasn't quite able to believe their kind denials, so I kept myself wide awake for 24 hours and checked off every 10 minutes in an exercise book, and he continued to do this. However, eventually he was found to not have a head injury and was discharged, from the hospital, much to his relief and the army's relief. Another very common and one disorder you will often see in general medical wards is conversion disorder or functional neurological symptom disorder. This is where there's one or more symptoms of altered voluntary motor or sensory function, such as a paralysis. The clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. For example, a person is describing weak ankles but can walk on tiptoe. The symptom or deficit is not better explained by another medical or mental health disorder, and the symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of function, or warrants medical evaluation. There are a number of symptom types specified. As I said, paralysis is very common, but other physical problems occur, such as abnormal added movement, for example, tremor, swallowing problems, speech problems, seizures, sensory loss, vision, smell, or hearing problem, or it can be mixed, and it can be with or without a specific or well-recognized psychological stressor. There's been some major changes to conversion disorder from the earlier understandings in earlier versions of the DSM. There has been a removal of the requirement that the clinician actively establishes that the patient is not feigning, that is not consciously putting it on, because it's usually very hard to actually determine that, and there's no evidence that feigning is more common than feigning of other mental health disorders. However, as with other disorders, positive evidence of feigning remains an exclusion, and this is what differentiates conversion disorder and factitious disorder and malingering. Second major change was removing the requirement that there had to be an established associated psychological factor. This is largely because it's often difficult to reliably establish this, and people often don't prefer it when they are interviewed. Also, the research evidence suggests that psychological factors can be found, but they're often very non-specific and often seem to have only a weak association with the diagnosis. Third major change is to emphasize the importance of obtaining positive evidence of the diagnosis from appropriate neurological assessment and testing. Coming back to the definition of abnormal illness behavior, where a patient has to be adequately assessed and investigated to make that conclusion. Conversion disorder was formerly known as hysteria and has been around quite a long time. The term hysteria was based on the Egyptian theory of the wandering uterus, which was credited to Hippocrates. And in 1859, Briquet used that term to describe the hysterical personality. And then the great French neurologist, further, Charcot, used hypnosis to elucidate and manipulate the clinical signs of the disorder. And in the 20th century, Freud proposed that an unconscious conflict is symbolically converted into a somatic symptom, whereby the term conversion disorder started. So this is where we come to some medical histories. And this is an account of the events in Salem, which I'll just let you stop and pause and read yourself. Now, I was always struck by this photograph on the next slide, actually not photograph, pictograph on the slide, of the events in Salem, which show learned physicians holding the woman who's fallen down, other learned physicians sort of examining a woman, and the sort of general hysteria, concern around the fact that so many women were becoming unwell. But what I find striking is that one looks at the same events seeming to be happening at the sort of start of the 20th century in John Martin Charcot's famous laboratory, where people like Guy de la Tourette, down in this photograph, came to study, and the same thing, that the woman falling down in a conversion disorder state into the arms of someone else who's fairly famous, Joseph Babinski. So now coming to factitious disorder and malingering. They differ from conversion disorder in that there is a voluntary production and presentation of false or grossly exaggerated physical or psychological symptoms. The difference between fictitious and malingering is that this voluntary production in malingering is for external incentives, that is in pursuit of a goal that's obviously recognizable within an understanding of the individual's circumstance, for example, to avoid military duty. A good example of fictitious disorder comes from The Good Weekend in 2011, which was entitled Munchausen by Internet, Munchausen being another earlier term for fictitious disorder. Querying, was this a new psychiatric disorder? This was about JV, who ran an online business. She described herself as an outcast, alienated from her family with few friends. But she does have a real medical condition, a rare autoimmune deficiency. But when she joined a worldwide online support group for fellow patients in 2008, she found herself exaggerating her symptoms and fabricating other persona to draw attention to herself. And she said that she was very good at this at first. I didn't lie then. But then she got caught up in a whole range of lies because everyone felt for me and it felt wonderful. Somewhere along the way, she said she got lost and she had never felt more loved and cared for in her entire life. She then felt genuinely ill and took a break, and then when she went back online, she found people were looking for me, and that was when she started to post a whole range of further lies and told the group that Jay was in a coma. There was a deluge of compassion, and she felt really good about this, spending time with people who genuinely cared for me, even if they didn't know I was a fake, and she found she couldn't stop. And it went on for further months until she said it finally dawned on her she was playing with people's emotions, and she confessed. She got a barrage of abuse after this, people telling her she was the lowest, most despicable person that ever existed, and she's still getting emails, messages from members 2 years on. However, on a happier note, she is receiving psychiatric help and takes medication for depression and has developed good insight into what happened when she developed this fake life of this ill person. Malingering, in contrast, is where there's an external incentive. So one suspects malingering where there may be a medico-legal context of the presentation, where there is a very marked discrepancy between claimed distress and objective findings. The person is not cooperating with assessment, and often the person may have a comorbid antisocial personality disorder. This last fight out of Stalingrad photograph is just from the Second World War, because this type of malingering occurs very commonly in soldiers at war, and particularly in places such as Stalingrad, where they were faced with overwhelming loss and likelihood of injury and death. So people, of course, began to have self-inflicted wounds. I'll let you read through the description of that. And another one posted perhaps more recently, more up to date, of Bill Gibson at a Cosmopolitan event in Sydney. What was her story? She used blogging to promote a wellness, lifestyle and nutrition program called The Whole Pantry. She documented her medical crisis and survivals of uterine, spleen, blood and brain cancer, was highly successful with 200,000 follow-ups, and she was just about to be signed up by Penguin Books when she was exposed. And lifelong history of her near-death experiences were publicly accounted for. In terms of how common are these disorders, somatoform disorders occur very commonly in practice, but particularly in general medical and in general family practice settings, and maybe in up to 16% or almost 1 in 5 of people with presentations may have a somatoform disorder. They are less common in psychiatry. People with conversion disorder do not usually present to psychologists or psychiatrists, but they do commonly present, as I said, to general medical and other physicians, and particularly in neurology. And they are also commonly found in children or people with less maturity, and in certain cultures where there is a lot of stigma about psychiatric illness, and thereby developing a somatic disorder is a more culturally acceptable way of having a medical problem or mental health problem. This is just a graph showing the overlap with other psychiatric disorders in general practice, and within somatoform disorders, around 26% or 1 in 4 people will have an anxiety and or depressive disorder, and with that anxiety and or depressive disorder, almost half may have some form of somatoform disorders. So although they're not always occurring together, there is a high rate of comorbidity. What can we do about them? It's very important for the doctor to recognize the problem and convey a non-blaming understanding, and I can't emphasize that enough. A non-blaming understanding. Give informed advice on outcome and treatment, using physical, psychological and social treatments in a coordinated approach. So very important for the psychiatrist and psychologist to be one with the physician or general practitioner or physical health therapist who's looking after the person. In conversion disorder, for example, someone who comes into hospital with paralysis, one should say, I've seen this before, I know what the problem is, I know that you will recover from this. You'll recommend a graded rehabilitation program, usually with a physical therapy specialist such as a physiotherapist. It is very important, as I said, not to challenge the person, not to make the person feel humiliated, and say things like, it's all in your head, is very much a no-no. It is also important not to reinforce the behaviour or secondary gain with, for example, providing the person with a wheelchair. You need to anticipate recovery and start an active program of rehabilitation to recover the ability to walk again. And you need to consider it's very likely there may be psychiatric or psychological comorbidities, particularly anxiety and depression, and offer therapy and help for those. One can talk to patients about the neurobiology. It's unclear if this is helpful. I would think it's perhaps not as helpful as a positive anticipation of recovery and starting active rehabilitation. But there is a neurobiology. This is just from a Lancet paper, quite old paper now, but just showing that when someone with a conversion disorder, a paralyzed leg, was asked to move their leg, there was increase in blood flow in the orbitofrontal and anterior cingulate cortices, but not in the motor cortex, supporting the hypothesis of a prefrontal inhibition of motor and sensory cortex by limbic affected areas. It is also important to remember that psychosomatic disorders can have very good outcomes if people are identified early and have active and early treatment and avoid perpetuating factors, and in particular avoid a range of secondary gain. Most people will recover from their somatic symptom disorder. However, not always. This is just a short story about Louise by another British author in the first part of the 20th century, around the same time as Noel Coward. I'll let you read through the short story yourself about a woman called Louise who had a heart condition. Move to the next slide. And the third slide. Finally, Louise had a daughter, Iris, and I'll let you read about how she felt about Iris being useful and taking care of her. However, Iris wanted to get married and fell in love. The author, or the writer, confronted her. And Louise said, "One of these days you'll be so dreadfully sorry you said this to me." So after the confrontation, Louise allowed Iris to get married, and on the wedding day, she had her heart attack and died, gently forgiving Iris for having killed her. So this is just a little bit of fun. This is showing Noel Coward with his daughter Liza at her wedding in 1936. So what do you think is the disorder depicted? Was it conscious? Was she actively inventing the heart condition? Or was it unconscious? And was she just getting a whole range of secondary gain from the condition which perpetuated it? I would tend to go for the latter, that it was unconscious. Was the end unexpected? Not really. Many people with somatic symptom disorders or somatoform disorders have genuine medical conditions as well as the psychological condition, and may well have overlapping symptoms and signs of both. People with severe asthma can also have severe anxiety and breathlessness related to the anxiety. So in some respects the end was not unexpected. Another approach, and this is where I cannot say too much, is to not have confronted her, not to have humiliated her, not to have caused that major stress, and also drive her to needing to show how unwell she was, but perhaps to have worked out a way of giving her support, having some of her needs met, but also perhaps allowing for her daughter to marry and become independent. There may have been some other way forward than that rather brutal confrontation. So, another bit of fun. I want you to think about, perhaps if you wish, if you don't wish, just go straight to the next slide. Who is this woman and what DSM-5 somatic disorder did she have? And if you want to email this to me, I will take a random sampling of all the correct answers that I receive, and the lucky winner will receive a prize. I suggest you take a break now before going on to the next lecture on eating disorders. So, eating disorders. On the DSM-5, there are three major eating disorders: anorexia nervosa, where people are underweight for their age and height, have an intense fear of fatness or gaining weight or behaviours to avoid weight gain, and a disturbance in the way in which they experience their body weight or shape that causes an undue influence of their body weight or shape on their self-view or denial of the seriousness of being low weight. There's no specific level of low weight that is set. It is that is underweight for their age and height, but there's no specific BMI. Bulimia nervosa, by definition, people are normal weight or overweight, and they have recurrent binge eating or uncontrolled episodes of overeating large amounts of food, and they use extreme measures to control or counteract the overeating and to control their weight. And this can be both purging types, such as vomiting or laxative misuse, and non-purging types, such as extreme exercise or extreme dieting and fasting. And there is binge eating disorder, where, as in bulimia nervosa, people can be normal weight or overweight. They have recurrent binge eating episodes, but they do not have extreme compensation, either purging or non-purging, and because of that, they are often overweight. And there is a new disorder, avoidant restrictive food intake disorder, which was new in 2013. This is where there is an eating or feeding disturbance, including but not limited to an apparent lack of interest in eating or food, avoidance based on the sensory characteristics of food, or concern about aversive consequences of eating, as manifested by persistent failure to meet appropriate nutritional and or energy needs associated with either significant weight loss or significant nutritional deficiency or dependence on enteral feeding or nutritional supplements or marked interference with psychosocial function. Insufficient food or an associated culturally sanctioned practice does not account for the disorder, and it doesn't occur exclusively during anorexia nervosa or bulimia nervosa, and there is no evidence of a disturbance in the way in which one's body weight or shape is experienced, and is not better accounted for by a comorbid medical or mental health problem. In thinking about the prevalence and determinants, we know very little about ARFID as it's a new disorder. So what I'll be saying mostly is about anorexia nervosa, bulimia and binge eating disorder. The estimated lifetime prevalence in the community of anorexia nervosa is under 1% and bulimia nervosa around 1% or just below, and binge eating disorder is the most common and it's around 2% or more, and it seems to be increasing. This is just another bit of fun. This is showing you the Venus of Willendorf, which is one of the earliest stone statuettes found in sort of Western culture from the Paleolithic era, but obviously depicting a body image that's very different from the one that we consider the ideal today. This is another bit of whimsy. You can flick across this if you don't want to read it. It's just an excerpt from a story by Alexander McCall Smith about an African woman who lived in Botswana, noticing that the mannequins modelling the dresses were all waif-like and thin, as if the slightest wind might come and blow them away like so many leaves, and she wondered why were there not any traditionally built mannequins? Why were there not comfortable ladies in the window, ladies with whom those on the other side of the glass, as in her, could identify? That was another thing women had to be wary of, she thought. Another way of putting women down, telling them they should stop eating. So our concerns about body image in our culture definitely interplay with the presence of eating disorders in our communities. These cultural influences likely explain why there are more women than men who have anorexia nervosa and bulimia nervosa, although the rates of binge eating disorder are more equitable between the genders. It is higher in North American and similar westernized cultures, and migrant studies support that. As people migrate from less Western to more Western societies, the rates of eating disorders go up. And it's lower in rural areas in contrast to obesity, which tends to be higher in rural areas. However, there is an increasing prevalence in men, in older people, and in lower income groups, and across the world, and it's now very, very difficult to find somewhere in the world where there is not people with eating disorders. In addition to these cultural influences, genetic influences are important as well, and there is a significant heritability of greater than 50% for all eating disorders, and likely susceptibility genes will be identified in the future. There are also some familial factors that run in people with eating disorders, and in particular people who have anorexia nervosa tend to come from families where the physique is lean, and people who have bulimia nervosa tend to come from families where people are overweight or obese. Also, in people with eating disorders, there's often a family history of mood disorder, of substance abuse, and in people with anorexia nervosa, there's often a family history of obsessionality and obsessive compulsive personality disorder. There are a range of environmental influences and risk factors. Early menarche is a risk factor, and this is even when controlling for BMI, which of course obesity is a risk factor for early menarche as well, and there is an overlap between the risk of obesity and the risk of eating disorders. In bulimia nervosa and binge eating disorders, self and familial dieting is very common, as is childhood obesity and having critical comments about your weight as a child. In both eating disorders, anorexia and bulimia nervosa, there is often a personality style of extreme perfectionism combined with a lack of belief in oneself and low self-esteem. And there's a range of at-risk occupations, including classical ballet and some intensive sports. And, in addition, a range of non-specific psychological risk factors such as sexual abuse, which occur and increase the risk for eating disorders as well as other psychiatric disorders such as depression. In terms of outcomes, anorexia nervosa typically starts in the mid-teen years, but it has a great range in terms of course and outcome. Younger people with a briefer history of anorexia nervosa tend to have a short-lived illness and respond well to treatment. Older people with longer history tend to become intractable, and around 1 in 10 or 1 in 5 may develop a severe and enduring or intractable and unremitting course. Around about 50% may develop bulimia nervosa or another eating disorder, and unfortunately there still is a raised mortality rate for people with anorexia nervosa that is quite significant. Bulimia nervosa tends to have a later age of onset, occurring in the late teens and young adulthood. Symptoms can be very chronic, but they do remit over time, and around 50% may be remitted at 5 to 10 years. There are some things that are important predictors of outcome for bulimia nervosa, and these include being overweight as a child and having low self-esteem and a personality disturbance, who do less well in outcome. In terms of treatment for all eating disorders, there's 2 important threads. The first is to restore their physical health, and the second is to restore psychological well-being using a range of psychological therapies and drug therapies. It's very important to assess physical status, and in blue on this slide are the things you really do need to know about: dental problems, gastric problems, and cardiovascular compromise. There's a range of endocrine abnormalities, and again I put in blue something you do need to know about, which is the osteopenia, because it may be preventable and certainly may be reversible. Other endocrine abnormalities are present, but often not part of active concern or treatment. People may present with an eating disorder to the emergency department most often in a medical crisis with low potassium from vomiting and dehydration and cardiovascular compromise, and or with a psychological emergency and self-harm and suicide. And it's important to remember that as many patients with anorexia nervosa may die of suicide as they may die of medical complications of the severe starvation. In terms of assessing risk in the emergency department, severe low weight combined with rapid weight loss is a sign of increased risk and need to have urgent medical attention, as is being pregnant or having medical or cardiovascular or metabolic compromise, and if someone is at a close state of physical collapse, for example, cannot rise from a squatting position, and of course if someone has active suicidal ideation, one should consider admission. I'm just revisiting a little bit of what we talked about in the very first campus learning week, cognitive behaviour therapy, because that's the mainstay of psychological therapy for all eating disorders. Cognitive therapy is a rational disputation of the patient's belief, such as in eating disorder, the moderation of extreme concern about shape and weight and generation of alternative attitudes. And behaviour therapy, which comprises behavioural experiments functioning to help the person disconfirm their original conclusion and confirm alternative beliefs. Cognitive behaviour therapy classically was developed first for bulimia nervosa and is presented to patients in stages which are listed here. It is based on a personalised view of the onset and the perpetuation of the eating disorder by concerns such as extreme weight and shape concern, leading to dieting, getting into a vicious cycle with binge eating and compensatory behaviours driven by things that may have happened or occurred to the person early in their life, such as sexual abuse or other abuse, having a low self-esteem, coming from a culture of high valuation of thinness, such as being a ballet dancer, and having perceived or actual overweight in their childhood. In cognitive behaviour therapy, there is a psychoeducation phase where often we talk to people about this study, the classic study of biology of human starvation by Keyes. We talk to a person what happens when the body is starved. This was a study of 36 young men, volunteers, who were starved for around 6 months, lost a lot of weight and became intensely food preoccupied. They all developed abnormal eating behaviours, as you can read on this slide, including things very common in people with anorexia nervosa, such as food rituals. In addition, they had a range of other psychological effects. Again, we see these in people with eating disorders, in particular mood changes, self-harm, mood swings, loss of concentration, apathy and alertness. In terms of the next phases of cognitive behaviour therapy, we start the person monitoring their eating and weight control behaviours. They need to do this using a standard form, record everything that they eat. Often these days they may do this on their computer or on an app, and this helps them actually record in real time rather than just before the next appointment or once a day. And then they bring the records to the sessions, to the therapy sessions, where with the therapist we look for patterns, times when nothing is eaten, times when binges are common. This is an example of a food record, typically of someone with bulimia nervosa who eats nothing in the early part of the day, then starts to binge, feels guilty, gets very hungry, goes home again, binges, goes to bed, very unhappy, resolving not to eat the next day. So really much in the binge fast cycle. The next phase of therapy in CBT for eating disorders is to institute a meal plan, decide on times for eating, decide ahead of time what food to have, don't wait until you're really hungry, stick to the plan, and in particular avoid making up for binges. This is all about learning to eat again and learning to enjoy food, so having a comfortable relationship with food. So it's very important for the person to expose themselves to all sorts of food and include all foods in their meal plan, even if only in very small quantities initially. In eating disorders, you need to have a good understanding of nutrition and use something such as this food plate. This is the one from Northern Territories, which I think is fun because it's got a kangaroo in the bottom and some barramundi. Either this food plate or a food pyramid, and as a basis for nutritional counselling and what is normal eating. The next phase of therapy goes into learning to intervene to prevent the eating disorder behaviour, so developing strategies to do that, distraction strategies, talking to someone, planning ahead, relaxation strategies, also helpful if the person has anxiety, and graded exercise, also helpful if the person is not very fit or is very overweight, which can help them develop a sort of better relationship also with their body as it becomes fitter and more toned. Problem solving is a generic psychological therapeutic approach that's used in a whole range of disorders, including eating disorders, but it's also very effective in mild depression, and it's based on a premise that there's no problem that can't be solved, but it must be defined well. There are always more than one solution. There are advantages and disadvantages to all solutions. One generates those and then chooses a solution, tries it out and reviews it, because the first solution that's chosen may not be the one that ends up being the most appropriate. On this slide I've got an example of a problem-solving dialogue, which I'll just let you read through at your leisure. It's one that's related to eating disorders, and it's solving the problem of not being able to eat at work, not being able to eat regularly. The next phase of therapy is to eliminate dieting by eating regularly, normal quantities, reintroducing forbidden foods in a hierarchy so the person can feel comfortable around any form of foods. In refeeding and anorexia nervosa, this will be occurring at this stage where you're reintroducing foods. It's important to go low and slow and aim, particularly in outpatient therapy, at a very low rate of weight gain of about 0.5 kilogram per week. Remembering that refeeding can be problematic, it can lead to refeeding syndrome. There can be different ways of doing this, but it's best to do it as much as possible in a collaborative way, and that's with oral refeeding, eating normal meals, as opposed to nasogastric or imposed refeeding. There is little evidence base for when and where, but it certainly can be done as an outpatient, particularly if the person has good family support, and you need to be cautious, as I said, of the refeeding syndrome. I'll let you read about that on this slide, but in essence it's a sudden introduction of large amounts of food, launching a demand for intracellular metabolic electrolytes, particularly potassium, phosphate and magnesium. So those are the things we monitor and watch for, and it can be very serious. We should note that people may be at increased risk for this if they've had recent and rapid weight loss and have already got some deranged metabolites. This is another little example of how a therapist and a patient might talk about forbidden foods and reintroducing forbidden foods into their diet. So I'll just let you read through that one at your leisure as well. And this is a clinical vignette about a refusal to eat dairy products. I'll let you read through that, but the important thing is that we're very lucky in Campbelltown. We have access to very good food allergists and experts who can advise us, such as Professor Brad Frankham and Professor Connie Catalaris. Very often people have a food allergy that's really not an allergy as such, but a food that may cause them to feel unwell, and they can be gradually re-exposed to that food, or they may be able to eat small quantities of that food and not need to eliminate it altogether from their diet. And moving into the cognitive phase of CBT, changing the person's mind. So challenging the person who values themselves according to their weight and shape and wanting to value themselves according to other aspects and more positive aspects of themselves as a person. Challenging perfectionism, black and white, all or nothing thinking, and introducing strategies to improve their self-esteem, such as new activities, new friendships, and always promoting the positive. These are just a list of common cognitive distortions as seen in people with eating disorders. I'll let you read those at your leisure. And again, another example of a vignette between a therapist and a patient of how you might challenge or address overvaluation of shape, in this case the person's view of themselves and their body, and trying to like different parts of their body, even if they can't like all of their body. Usually you can find some part of the person's body they can start to talk about and learn to like. Here is another vignette about fear of changes to their body shape, and again challenging the evidence for particular beliefs, that I've decided not to gain further weight because if I do I'll end up as a fat blob, and looking at the evidence for that. In this vignette, the therapist also explains to the patient that when one gains weight relatively quickly, it tends to go on as body fat. However, experience has shown that with time your weight will distribute itself automatically and you will tone up as you resume a more normal activity schedule. And the final phase is preventing relapse, noting that lapses will occur, but the person never goes back to baseline. And they will have and can compile a record of strategies to cope with lapses. For example, a lapse might be a resumption of binge eating under some stress. To cope with that, they may need to go back to resuming monitoring for a time and also review the distractions and other strategies that help them with their binge eating earlier in the therapy. And it's good if it happens during therapy, because you can exemplify that and show them that they haven't gone back to baseline and can get back on track and continue their recovery. And here is another vignette or encounter between a patient and a therapist about a lapse, just exemplifying those points. I'll let you read that. Cognitive behaviour therapy, as I said, was first developed for bulimia nervosa, but has been manualised since and developed for anorexia nervosa. Very much like for bulimia nervosa, moving through phases of therapy, starting with psychoeducation, building trust, then moving into changing eating patterns and behaviours, and then cognitive therapy, changing beliefs related to food and weight, and finally preventing relapse and preparing for termination. Also, cognitive behaviour therapy has been enhanced by various additional modules. This is one example from Fairbairn's manual, where he's added in sections on addressing clinical perfectionism, sections on improving interpersonal relationships using interpersonal psychological therapy approaches, sections on mood intolerance using approaches from dialectical behaviour therapy that we talked about in Campus Learning Week 1 or earlier in the year, and also on how to improve self-esteem. There is a problem, and this is particularly a problem with anorexia nervosa, that most patients who present are not in a stage of active change or even preparation for change. Therefore, motivational interviewing is very important and often can be the mainstay of psychological therapy in the early phases of treatment for anorexia nervosa. What is this aim of motivational enhancement interviewing? It's to help patients move from earlier stages into action using cognitive and emotional strategies. Open-ended questions are used to elicit the client's or the patient's expression, and reflexive paraphrase is used to reinforce key points of motivation. So most of the time is devoted to explaining feedback to the patient, and then later attention may be devoted to developing and consolidating a change plan. So this phase may last for quite a long time in the early stages of treating someone with anorexia nervosa. Examples of particular strategies that are used are to ask the person, what role or function does the eating disorder serve for you, and ask them to reflect on this and think about it and to come back and talk about it in the next session. And then, what role or function does the eating disorder serve in your family and other relationships? Ask them to think about this, maybe think about it in between sessions, come to the next session and talk about it more. We also might ask them to draw up a list of the pros and cons of having an eating disorder and reflect on that. And reflect on decisional analysis of the positive and negatives of particular aspects of the eating disorder: if I gained weight, if I lost weight. And life without an eating disorder. And I really like this particular exercise. I find it very, very useful in helping patients to start thinking about change from their eating disorder. So I'll let you read through the actual exercise. And then they're asked a series of questions to think about how did they feel. Imagine themselves going through a day, including having meals, going to work or school, having a relationship, without having the eating disorder. Finally, family therapy is a mainstay of psychological therapy for eating disorders, particularly in children and adolescents. The most common approach that's used is to actively engage and empower the family as collaborators in treatment, interviewing the family, including everybody who's living at home at an early stage, encouraging both parents to be present, letting the family know that it's not their fault that the person developed an eating disorder, and that it's understandable if there has been a lot of stress within the family, however, as a consequence of someone having an eating disorder. Family members, including siblings, are encouraged to share their feelings, and also often anger is felt and may be interpreted as an expression of concern. If people are angry, then they are concerned, for example. Just to close, I have some algorithms for care in anorexia nervosa, bulimia nervosa and binge eating disorder. Anorexia nervosa involves a thorough assessment. You may consider going into hospital or not, depending on the severity of the anorexia nervosa. But as I said, many people can be treated as outpatients. There's no specific first-line approach, but there's definitely evidence that therapy provided by a specialist in eating disorders, either cognitive behaviour therapy, dynamic therapy, or a therapy called specialist supportive clinical management, is effective. And if people do not improve, then further, more active treatment may need to occur. For bulimia nervosa, after assessment, the first-line therapy is really a form of cognitive behaviour therapy, which can be converted into GSH or guided self-help forms, such as in a self-help book, but that's probably not as effective where there isn't a therapist involved as well, even if it is using a self-help book. And interpersonal psychological therapy or dialectical behaviour therapy also have some evidence in bulimia nervosa. And in addition to that, if people fail to improve or are very unwell, fluoxetine 60 milligrams a day or another alternative SSRI can be useful in helping reduce the behaviours, not specifically to treat depression, but to reduce the binge eating and extreme compensatory behaviours. And finally, binge eating disorder. Again, after assessment, cognitive behaviour therapy really is probably the first line treatment. Guided self-help and self-help books, however, are probably a bit more effective than if bulimia nervosa and can be used. If you're seeing someone and you're right out in the middle of Australia in the Kimberleys, there are books which can be helpful. And addressing concomitant obesity can also be helpful, so reducing the obesity and actually helping the person improve their eating and behaviours will reduce the binge eating as well. And like bulimia nervosa, SSRIs can be helpful to reduce binge eating.